If you haven't actually experienced shoulder pain yourself, chances are you almost certainly know someone who has. It's just incredibly common.
Oh, absolutely.
Hmm.
A really major driver of shoulder problems for, well, a huge number of people. It can really limit movement, cause a lot of discomfort.
And that specific problem, the rotator cuff tear, that's exactly what we're unpacking today.
Mm-hmm.
We had a listener share, well, quite a stack of material, actually. Notes, research papers, articles, all focused on understanding these tiers.
Right.
So this deep dive, it's kind of your shortcut. We're pulling out the key insights so you don't have to wade through it all yourself.
Yeah, we're here to sort of walk you through the essentials.
Yeah.
And what's immediately clear, just dipping in this material, is that, a rotator cuff tear isn't just one simple thing.
Right.
It shows up differently depending on who you are. Maybe
Right.
you're younger, had a sudden injury, or perhaps older, and it's something that's developed gradually over time.
So our mission here, really drawing from these sources, is to get a proper handle on what the rotator cuff is, first of all. Then how doctors figure out if you actually have a tear, because it sounds like it's more involved than just a few arm movements in the clinic.
It is, yes.
And then, crucially, the treatment paths, they seem surprisingly varied based on this info.
Yeah, and there are some pretty striking facts that jump out right away,
Yeah.
like prevalence. This research, it shows that full-thickness tears, so right through the tendon, they're found in a significant percentage of older people,
How significant.
around 28% in those over 60. And get this, it jumps sharply to 65% in people over 70.
65%. Wow.
Uh-huh.
That's huge. So it's definitely not just about sports injuries then.
Not at all. And the material, it also points to other risk factors beyond just getting older. Things like smoking, high cholesterol, even having a family history seems to play a role.
Interesting.
Exactly. It's often a mix of things.
Yeah.
And while, clinical tests in the doctor's office can definitely raise suspicion, the sources really emphasize that. Confirming it, getting the full picture, usually requires imaging. And MRI tends to be the go-to standard there.
Okay. And treatment, because the material makes it sound like, well, there's no single answer.
Absolutely not. It's made very clear this is not a one-size-fits-all situation at all.
Okay.
Decisions are highly tailored. You have to look at the tear itself, the size, where it is, but also the patient's age, what they actually need their shoulder to do in their daily life. Even the condition of the muscle itself is a big factor.
Right. Okay. Let's start right there then, just to get everyone oriented. What exactly is the rotator cuff, and why is a tear such a big deal?
Okay, so think of the rotator cuff as a team, really. A crucial team of 4 muscles and their tendons that surround your shoulder joint.
Okay.
You've got the supraspinatus, infraspinatus, teres minor, and the subscapularis. Now, their main job isn't just moving the arm, although they certainly help with that. It's primarily about providing dynamic stability.
Dynamic stability.
Yeah, they essentially work to keep the ball of your upper arm bone, the humeral head, nicely centered in the socket. They create this stable platform so that your big deltoid muscle, the one on the outside of your shoulder, can lift and move your arm effectively.
Ah, okay. So they're kind of like the fine-tuners, keeping the big movements smooth and under control.
Precisely. They work together, often in opposing pairs, sometimes called force couples, to balance all the forces around the joint and maintain that crucial stable center of rotation.
Got it.
So when one or more of these tendons tears, that balance gets disrupted. And that's where you start running into problems, pain, weakness, difficulty moving the arm properly. Restoring that stable balance, that's the fundamental goal, really, whether the treatment ends up being surgical or non-surgical.
That makes sense, stability being key. And the material we looked at, it discusses different ways these tears actually happen. It's not always one big dramatic event, is it?
That's right. Actually, the most common way tears seem to develop, particularly in older individuals, is through gradual degeneration.
Like wear and tear.
It's exactly like wear and tear over time. The tendon tissue itself just weakens, starts to break down from within, sort of intrinsically. And these degenerative tears, they most often affect the muscles at the top and back of the shoulder, the supraspinatus and infraspinatus.
So aging is definitely a major factor here then.
Absolutely. The sources also mention chronic impingement as potentially playing a role in this degenerative process too. That's where the tendon might get pinched under the bone, the acromion, during certain arm movements.
Okay.
But then, on the other hand, you do have acute tears. These are often sudden, traumatic injuries, tearing a tendon during a fall, maybe a shoulder dislocation, or some specific forceful movement. These tend to be more common in younger, more active people.
And I think I noticed the sources also mentioned something about tears caused by previous surgery itself. Is that right?
Yes, unfortunately, that can't happen.
Yeah.
A repair from a previous surgery can sometimes fail. This was noted particularly for tears involving the subscapularis tendon. That's the one at the front, sometimes occurring after certain types of surgery on the front of the shoulder.
Okay.
And the material also points out that for athletes, especially those who rely heavily on their shoulders, like throwing athletes, well, even full-thickness tears often end up needing surgical repair because of the sheer demand placed on that joint.
Right. So if someone turns up with shoulder pain, how does a doctor typically start to figure out if a rotator cuff tear is the cause? Based on this information anyway, the material mentioned clinical tests first.
Yeah, the physical exam is definitely step one. It's about raising suspicion. Doctors use specific tests that try to isolate each of the rotator cuff muscles, or at least put stress on them.
Like what kind of tests?
Well, for example, they might check for witness when you try to lift your arm out to the side in a specific position, or see if you can hold your arm up against gravity after they've lifted it for you. If your arm just drops uncontrollably, well, that might suggest a significant tear.
I think I've seen that one where they lift your arm up and then ask you to just keep it there.
That's likely the drop arm test, yes. Often used to look at the supraspinatus. But there are other tests, too. Tests for external rotation strength, turning your arm outwards, which checks the infraspinatus and teres minor, or tests like the belly press or the liftoff test for the subscapularis muscle,
Yeah.
the one that handles internal rotation, turning the arm inwards.
Okay.
Even finding excessive passive external rotation can be a clue suggesting a subscapularis tear.
But these clinical tests, they're not the whole story, are they? The material seemed quite clear on that.
No, not at all. They can give a strong indication, absolutely, and they help guide the examination, but they can't tell you the really precise details. Things like, exactly how big the tear is, precisely where it's located, or whether it goes all the way through the tendon, a full thickness tear, or if it's just partial.
Right.
And that's why imaging is almost always needed. You need it to confirm the diagnosis and really get those crucial specifics.
And the material we reviewed really highlights MRI as the sort of standard imaging method. Why is that the case? What does MRI show?
Well, MRI gives a really fantastic, detailed look at the soft tissues, so the tendons and the muscles themselves. It's essential for seeing the size of the tear, its shape, and how much the torn end of the tendon has pulled away or retracted from the bone.
Okay.
And crucially, it also gives vital information about the muscle itself, particularly whether it's undergoing what's called fatty atrophy. That's where healthy muscle tissue gets replaced by fat over time because it's not being used properly due to the tear. The sources mentioned grading this using something called the Guttaglia system.
So you can actually see if the muscle itself is shrinking or turning fatty on the scan.
Exactly. And this is best assessed on specific views within the MRI scan. The MRI can also spot other associated issues sometimes, like problems with the nearby biceps tendon, or maybe cysts in the bone, which can sometimes be linked to chronic tears.
The sources also mentioned X-rays and ultrasound. Do they have a role to play too?
They do, yes. X-rays are less useful for seeing the tendons directly, obviously, as they show bone best, but they can show important secondary signs. For instance, if the ball of the upper arm bone, the humeral head, has shifted upwards in the socket relative to the glenoid, well, that can indicate a long-standing, pretty significant tear. It means the rotator cuff isn't doing its job of holding it down properly. This proximal migration, as it's called, is a key sign on an X-ray.
Okay.
X-rays can also show other things like bone spurs or the shape of the acromion bone above the rotator cuff, although the direct link between acromion shape and tears through impingement theory is perhaps debated more now than it used to be.
And ultrasound?
Ultrasound's another option. It's generally cheaper than MRI, and it can look at the tendons dynamically while you move, but its effectiveness really depends heavily on the skill of the person doing the scan, the operator. And it's generally not considered as good as MRI for seeing deeper structures or evaluating that muscle quality, the fatty atrophy we mentioned.
One thing that really stood out from this material, quite thought-provoking really, was the statistic showing that a significant chunk of people, especially older adults, actually have rotator cuff tears visible on an MRI scan. But they don't have any symptoms at all.
Yes, this is a critical point raised in the sources, a really fundamental observation. It tells us that just having a tear show up on an image doesn't automatically mean you're going to have pain or problems with function.
Right.
And this disconnect is really fundamental to how doctors approach managing these tears,
Mm.
especially the chronic degenerative ones you see in older, maybe less active individuals.
It sounds like really understanding the specifics of the tear itself is absolutely key then for deciding what to do next. The material broke down how these tears are classified quite systematically.
Yes, and that classification is important. It gives doctors a common language, and it definitely helps guide those treatment decisions.
Yeah.
Tears get described in several ways. First, by which tendon or tendons are involved. Is it the ones at the top and back, the supraspinatus, infraspinatus, teres minor, sometimes called the SIT tendons, or the one at the front, the subscapularis? Then they're classified by size, often measured in centimeters across the greatest dimension. You hear terms like small, medium, large, or massive.
And massive usually means?
Massive typically means 2 or more tendons are torn.
Okay, size seems fairly straightforward. What about partial tears? You mentioned full thickness earlier.
Right, so partial thickness tears, as the name suggests, don't go all the way through the tendon's depth. They're further classified by how deep they go, say less than 50% or more than 50% of the tendon thickness, and also where they are located.
Where they're located?
Yeah, are they on the joint side, which is called the articular side, or are they on the top surface, the bursa side, or are they actually within the substance of the tendon itself, which is called intratendinous?
Does it matter where they are?
Well, the sources note that articular-sided tears seem to be more common, perhaps due to factors like blood supply differences within the tendon. Bursal-sided tears, sometimes linked more strongly to that impingement idea, are occasionally considered perhaps more likely to need intervention, though that's debated.
And then there's the muscle quality you mentioned before, that Goutallier classification.
Exactly. This grades how much fatty tissue has infiltrated and replaced the healthy muscle tissue. It typically goes from grade 0, which is completely normal muscle, up to grade 4, where there's actually more fat visible than muscle.
And why is that important?
Well, the sources clearly indicate that higher grades of fatty atrophy, like grades 3 and especially grade 4, are generally a poor prognostic sign. It makes successful surgical repair less likely the tissue just doesn't hold stitches well or heal robustly, and functional recovery tends to be more challenging.
Okay. And finally, the material mentioned the actual shape of the tear matters.
Yes, the shape is really important, particularly for surgical planning, if surgery is being considered. Tears can have different configurations. Common ones are described as crescent-shaped, U-shaped, or L-shaped.
How does that affect surgery?
Well, crescent tears are often still quite mobile and can sometimes be pulled back directly to the bone, their original attachment point or footprint, and repaired there. U-shaped and L-shaped tears, however, tend to be more retracted, pulled further away. They often require specific surgical techniques to bring the edges of the tear together first, like converging the sides of the U before attaching the tendon back to the bone. This helps to reduce tension on the final repair. Massive tears that are very retracted and stiff, well, they represent the biggest surgical challenge.
Okay, so we've got a handle on what they are, how they're diagnosed, how they're categorized in quite some detail. Let's move on to treatment then. The materials seem to indicate that quite often the first approach isn't actually surgery.
That's absolutely right. For the majority of chronic degenerative tears, and for many partial tears that aren't causing significant weakness, and even for some full-thickness tears, especially in less active individuals, starting with non-operative treatment is the standard approach.
And what does that typically involve?
It usually involves a few things. Modifying activities, basically avoiding the movements that cause pain, especially overhead stuff. A structured physical therapy program is key, aiming to strengthen the remaining healthy parts of the rotator cuff and the other muscles around the shoulder, like the deltoid and scapular stabilizers. This often goes on for several months.
Right.
And sometimes injections, like corticosteroid injections, might be used to help manage pain and inflammation, particularly if there are strong symptoms suggestive of impingement alongside the tear. The material suggests that many partial tears, in particular, can improve quite significantly with just therapy.
Okay. And if that non-operative approach doesn't provide enough relief, or perhaps for certain types of tears from the outset, that's when surgery comes into the picture.
Correct. Based on the information provided, surgical repair is generally considered for acute, traumatic, full-thickness tears, especially in younger, active patients. It's also considered for certain significant partial tears, perhaps deeper articular-sided ones, or maybe some bursal-sided piers that fail to improve.
And for the older patients with degenerative tears.
It's definitely an option for them, too, if they have significant symptoms like pain and weakness that really impact their function, and they haven't responded adequately to a good trial, usually several months of non-operative treatment. But, and it's an important but, the muscle quality needs to be reasonably good without that advanced fatty atrophy we talked about.
Now, the material mentioned different surgical techniques, things like arthroscopic versus mini-open.
Yes, many open approaches, which involve a small open incision combined with some arthroscopic work, were quite common previously. But nowadays, most rotator cuff repairs are performed arthroscopically. That means using small keyhole incisions and a camera to view the joint and instruments to perform the repair.
And the advantage of arthroscopic.
Well, it often means smaller scars, potentially less disruption to the surrounding muscles like the deltoid, which might allow for slightly earlier range of motion exercises after surgery, although protocols vary. While some earlier studies showed quite similar outcomes between the two approaches, arthroscopic repair is certainly the predominant technique used today. It is, however, technically demanding for the surgeon.
And within the arthroscopic world, there seemed to be discussion about single row versus double row repairs or something called suture bridge techniques. What's that about?
Right. This refers to the specific way the torn tendon is reattached to the bone using sutures and anchors. Newer techniques like double row or suture bridge configurations aim to recreate more of the tendon's natural attachment area, its footprint, on the bone.
Why do that?
The theory is that this provides a stronger, more biomechanically sound repair and potentially promotes better feeling between the tendon and the bone. The sources do reference studies showing biomechanical advantages for these more complex techniques compared to simpler single-row repairs.
Does it make a difference clinically?
That's the million-dollar question. Whether these biomechanical advantages consistently translate into significantly better long-term clinical outcomes for patients is still debated in some contexts. The specific technique chosen often comes down to the surgeon's preference, their experience, and, importantly, the specific characteristics of the tear they're dealing with.
It sounds like even with sophisticated surgery, healing isn't always a guarantee. The sources definitely discussed potential complications, including the risk of the tear actually coming back.
That's a very significant point the material covers, yes. Probably the most common reason for a repair to fail, in structural terms, is that the tendon doesn't successfully heal back down to the bone. It re-tears, or perhaps never fully heals in the first place.
And are there factors that make that more likely?
Yes. The sources list several factors that are known to increase the risk of this re-tear or failure to heal. These include being older, generally over the age of 65 is often cited, having a larger tear size to begin with. Massive tears are much harder to heal, poor muscle quality, that fatty atrophy again, certain medical conditions like diabetes or being a smoker. If the original tear was very retracted, pulled far away from the bone, and unfortunately not following the post-operative rehabilitation program diligently is also a major factor.
Right. So even after you've had the surgery, patient factors and just how bad the tear was originally still played a huge role in the final outcome.
Absolutely. The biology has to work. The material also mentions other, less common complications like postoperative stiffness, infection, or very rarely nerve injury. But that re-tear or failure of healing is the primary structural concern after repair.
What happens then if a tear is just so large or the muscle quality is so poor that it's considered, well, not repairable in the traditional sense? Are there still options?
Yes, the sources do discuss management options for these very challenging situations, the massive, often irreparable tears. Sometimes the best option might be something relatively simple, like an arthroscopic cleanout or debridement, just smoothing down frayed edges and removing inflamed tissue to reduce pain, even if the tear isn't fixed.
Okay.
In some cases, a surgeon might attempt a partial repair, fixing whatever part of the tear is mobile, aiming to restore at least some function and balance. Then there are more complex reconstructive procedures, things like tendon transfers, where a healthy muscle and tendon from another part of the shoulder girdle, like the latissimus dorsi or pectoralis major, is surgically moved to try and take over the function of the torn rotator cuff. Or using a graft, either donor tissue or synthetic material, to reconstruct the upper part of the joint capsule, called superior capsular reconstruction.
And what about shoulder replacement?
For older patients who have significant arthritis in the shoulder joint, in addition to a massive irreparable tear, a condition sometimes called cuff tear arthropathy, a special type of shoulder replacement called a reverse total shoulder replacement might be the best option. These are generally considered salvage procedures, really, for when direct repair isn't feasible or hasn't worked.
Okay, so pulling together everything we've sort of explored in this deep dive, looking through all this material, what are the real big picture takeaways for someone listening?
Well, I think we've seen just how widespread rotator cuff tears are, haven't we?
Yeah.
And how they can happen in different ways, that acute injury versus the slow, gradual degeneration over time. We've also seen the crucial steps in diagnosis, starting with that clinical exam, but really relying heavily on imaging, particularly MRI, to get the essential details.
Right, the specifics matter.
Exactly. And we've really delved into how complex the decision-making process for treatment actually is. It's definitely not a simple yes or no to surgery. It's a much more nuanced choice.
Yeah, it seems heavily based on the specific characteristics of the tear itself. You mentioned size, location, whether it's partial or full thickness, even its shape. And also that all-important condition of the surrounding muscle, using things like the Goutallier grading for fatty atrophy.
Precisely. And layered on top of that is you, the patient. Your individual circumstances are fundamental. Your age, your activity level, what you actually need and want your shoulder to do. These factors are absolutely key in guiding whether non-operative management is the best place to start, or if surgery is considered, and then which surgical option might be most appropriate, knowing there's that whole spectrum of procedures available.
And the sources also remind us, importantly, that even after a surgical repair, that risk of re-tear is real. And it's influenced by many of those same factors we discussed: the original tear size, patient health habits like smoking or diabetes control, and critically, how well you stick to the recovery plan.
Yes, it's a complex interplay of biology, mechanics, and patient factors.
It really underscores just how much goes into managing these injuries effectively. Understanding all these different facets as laid out in this material we've discussed, it feels incredibly valuable. Whether you're, personally navigating this issue or maybe supporting someone who is, or even just wanting to expand your understanding of how our bodies work and sometimes don't work quite as planned.
It certainly does. And maybe the most striking insight, the one that perhaps really makes you pause and think, comes back to that point we touched on earlier about asymptomatic tears.
You mean the finding that so many people, especially over 60 or 70, have these tears visible on an MRI scan, but they actually don't have any pain or functional problems from them?
Exactly that. It just raises this really fundamental question, doesn't it? If this structural tear is there on the image, why does it cause significant problems in some individuals, but apparently not in others?
Hmm.
And how does that disconnect potentially change how we should think about diagnosing and, more importantly, treating these tears, particularly as people get older?
Yeah.
It really highlights that the image, the MRI finding, it's just one piece of a much bigger puzzle. The person's actual symptoms, their function, how it affects their life, that's just as important, if not arguably more important in many cases.
That is a truly fascinating point to end on. Thank you so much for guiding us through this really complex topic, drawing on all that material our listener provided.
My pleasure. It's always a great reminder of the depth involved in these conditions that might seem quite common on the surface.